Hello everyone and welcome to this presentation. My name is Mahsa Movahedan and I'm a PGY1 pharmacy resident at Abbotsford Regional Hospital. Today we're going to be talking about the use of colchicine in coronary artery disease through a review of literature. Our learning objectives for today would be to describe the proposed mechanism of action of colchicine in preventing coronary artery disease progression, understand the current evidence surrounding the use of colchicine for prevention of ACS, and apply current evidence to a patient case. Our patient case for today is CC. CC is a 62-year-old male who presents to the clinic for follow-up. He's status post an elective PCI, one drug-eluting stent in the left anterior descending artery for coronary artery disease in June 2020, and he's been stable ever since. He's otherwise healthy and is wondering if there's anything else he can do to optimize his therapy. He doesn't care about side effects. He doesn't care about cost. He's looking for anything that could potentially prolong his life or just prevent him from having any of these events ever again. Colchicine is a very well-known medication. It's indicated for gout, Behçet's disease, familial Mediterranean fever, pericarditis, Sweet syndrome, and vasculitis, for example. And the usual dosing range for colchicine is about 0.5 to 2 milligrams per day. Usually, inflammation leads to atherosclerotic plaque instability in CAD, which can lead to plaque rupture and thrombosis and eventually ischemia. And because inflammation is the main culprit, many anti-inflammatory medications have been studied for their potential benefit in ACS prevention. And colchicine is no exception. Anti-inflammatory effects of colchicine are different from NSAIDs or glucocorticoids. They act on tubulin, which is the protein in microtubules, and microtubules are responsible for cell movement, essentially. And so by inhibiting microtubule generation and polymerization, you can expect that you would have some changes in cell movement. You would see increased flow-mediated vasodilation, reduced platelet aggregation because cells just cannot move, and reduced inflammation because the inflammatory cells just cannot migrate to the site of insult. And so you can expect to see an inhibition of progression of atherosclerotic disease, acute plaque changes, and cardiac damage-induced cardiomyopathy and cardiac remodeling. And this is what we are looking for. And these are the proposed mechanisms of colchicine to prevent an MI potentially. Common side effects you can expect for colchicine include the respiratory side effects, about 1 to 10%, pharyngeolaryngeal pain, and GI side effects are very, very common, more than 10% diarrhea, nausea, and vomiting. There are contraindications for this medication, including serious GI, hepatic, renal, and cardiac disease, interestingly. Common interactions include digoxin, which can increase colchicine toxicity, similar to grapefruit juice. And also, if you take colchicine with statins, you will have an increased chance of myopathy. So my question was, in adults with coronary artery disease or ACS with an MI plus or minus PCI, does colchicine compared to placebo reduce mortality or cardiovascular events such as MI and stroke? I found this systematic review published in 2021 by Samuel et al., and they were looking at colchicine for secondary prevention of cardiovascular disease. They were looking at 4 RCTs, Colcott, Lodoco, Lodoco 2, and COPS trials. And their patient population was mostly patients who had clinically manifested coronary artery disease, either stable or post-ACS. When they pooled all these studies, they had about 12,000 patients, so quite a lot of patients. Most of these patients were 60 to 67-year-old males who were on statin therapy. They were comparing low-dose colchicine with placebo or control. Before we go over the outcomes, I wanted to go through each of these RCTs a little bit more in depth so that you can appreciate the nuances of these trials as well. So Lodoco 2013 was looking at patients who had stable CAD for 6 months at least. Not a super large study, about 500 patients only. And at about 2 years, they saw a decrease in composite of a bunch of outcomes. So ACS, out of hospital, cardiac arrest, and non-cardioembolic ischemic stroke. They did see mostly GI side effects in the colchicine group. Interestingly, the composite outcome was mostly derived by decreased ACS. For all of these studies that I'm going to be talking about, these trials excluded patients who had severe renal or hepatic insufficiency, and that's something to be aware of. The next study was Colcott, published in 2019. It included patients who had a recent MI within the last 30 days or so, and mostly patients who had it within the last 2 weeks prior to randomization. And this was a larger study, about 5,000 patients, and at 22.6 months, they saw a reduced composite outcome of cardiovascular mortality, resuscitated cardiac arrest, MI, stroke, and urgent hospitalization for angina requiring revascularization. They did see increased nausea and pneumonia in the colchicine group. Interestingly, their primary outcome was mostly derived by a decrease in stroke and urgent hospitalization for angina, and not by cardiovascular mortality or MI. The next study was COPS trial, published in 2020. This was an Australian study, looked at patients who were post-ACS, so more acute patients, similar to Colcott. These guys looked at patients after 12 months. They did give patients a loading dose of colchicine. So they, compared to the other trials, they were loading patients with twice daily 0.5 milligram for 1 month, and then stepping down to 0.5 milligram daily. Whereas the other trials that you can see here, they were just looking at 0.5 milligram daily from the beginning. At 12 months, they saw no statistically significant change in composite of these outcomes, so all-cause mortality, ACS, cardiac arrest, ischemia-driven revascularization, or non-cardioembolic ischemic stroke, and they actually saw an increase in non-cardiovascular mortality. So that was kind of concerning. And then Lodoco 2 trial came out in 2020. These were patients who had stable CAD for 6 months. A large study, 5,500 patients. And at about 28.6 months, they saw a reduction in composite outcome of CV death, MI, ischemic stroke, and ischemia-driven coronary revascularization, which was driven mostly by reduced MI, which is something we hadn't seen in the previous studies. Maybe in the first Lodoco, we did see some reduced ACS. And the ischemia-driven coronary revascularization was replicated in the Colcott study as well. And so there was this trend towards increased non-cardiovascular death, but not statistically significant. And they did see increased myalgias in the colchicine group. So they, once they pulled the results of these 4 studies, they saw that there was a reduction in composite outcome of cardiovascular mortality, MI, ischemic stroke, and urgent revascularization. And it was driven by each of MI, about 38% reduction, ischemic stroke, about 62% reduction, and urgent revascularization, about 44% reduction. But there was no difference in cardiovascular mortality. And in terms of secondary outcomes, they did see there was a trend towards more AFib with colchicine, but all-cause or non-cardiovascular mortality was not statistically significantly different between the 2 groups. And they didn't see any difference between infections, pneumonia, hospitalization for GI events, or cancer between the 2 groups. So it was really hard to explain that increase in non-cardiovascular mortality with some of those trials because they just couldn't pinpoint what the cause of it was. And it wasn't replicated in this systematic review here. So my bottom line was, at 1 to 2 years post-use, low-dose colchicine in patients presenting with stable coronary artery disease or ACS does not affect cardiovascular mortality, risk of hospitalization for GI side effects, infection including pneumonia, or cancer. However, it may reduce MI and ischemic revascularization, mainly in patients with stable coronary artery disease, and it may increase non-cardiovascular mortality, especially if a loading dose of 0.5 milligram BID is used in the first month. However, this was not replicated in the systematic review. It was non-statistically significant when the results of these 4 studies were pooled. If you do end up giving colchicine to someone, you would be monitoring for some symptom development. So for side effects, neuromuscular toxicity, which can appear as myalgia on a daily basis if they're in the hospital especially, or the patient can be monitoring themselves if they're not in the hospital. GI symptoms, nausea, vomiting, diarrhea, because they're very common on a daily basis again, either by the healthcare team or the patient themselves. And we would be monitoring labs, so CBC, serum creatinine, GFR, and LFTs. CBC because there are some immunosuppressant activities that colchicine can have, such as bone marrow suppression. So we would be monitoring that. Serum creatinine, GFR is just to make sure that we're giving the patient the best dose possible, because it requires dosage adjustment in renal impairment. And LFTs because colchicine can cause hepatic toxicity. And the frequency really depends on whether a patient's in the hospital, because we can just do it more frequently if they're in the hospital, or it would just be less frequent if they are in the community. So going back to our case, CC, who was a 62-year-old male and presented to the clinic for follow-up, it seems like he's been pretty stable for over 6 months now, ever since he had his PCI, and he's otherwise healthy, doesn't have any other medical conditions. So if we were to add colchicine to his medications, based on my bottom line, I would expect that it would potentially reduce his risk of MI and stroke. But there was that increase in non-cardiovascular mortality in patients who were given a higher dose of colchicine in the first month, and there was a trend in other patients who had stable coronary artery disease. And so this still worries me and is in the back of my mind, and because the trials showed a composite of a whole bunch of outcomes, and they weren't specifically powered to show MI benefit or ACS benefit, it's hard to infer their benefits for sure as well. And so I wouldn't personally recommend it to any patient with coronary artery disease unless there are, like this patient, they are asking for anything extra that they can do. And I would explain the risks, I would explain the benefits, and let the patient decide at that point if they want to go ahead with colchicine therapy. You can see that different experts have different opinions about this. Dr. Mandrola, who's a cardiologist, has said that when you look into the nuances of these trials, the degree of benefit from colchicine looks a lot less certain. The higher death rate in LOTOCO 2 really worries me. When the harm-benefit calculus is uncertain and there's no urgency to act, I favor the precautionary principle. I would not recommend use of colchicine in patients after MI. Dr. Buabdoloy, I hope I'm pronouncing her name right, who is also a cardiologist and is a author of one of the authors of the systematic review that we just reviewed, has said that given that it provides large benefits on cardiovascular events safely and in a cost-effective manner, low-dose colchicine therapy should be considered for all patients with coronary artery disease with no severe renal dysfunction. So you can see that there's quite a debate going on between experts as well. And I'm hoping that with the information I have provided you, you can make up your own conclusion and provide your patients with the best available evidence, and also let them decide what is best for them as well, in collaboration with you. Thank you so much for listening. And if there are any questions, please feel free to email me at masa.movahedan@fraserhealth.ca.